we move on to the next session, that is management of oncological pain. So to chair the session, I would request Dr. Nang Sujali, Associate Professor, Department of Anesthesia at Abwims and Dr. RML Hospital. She has over 15 publications, one book, and her special interest is in neuroanesthesia, pediatric anesthesia and critical care. Welcome, ma'am. I would also like to invite Dr. Shagun Bhatia, who is the consultant, Department of Anesthesiology and Critical Care, Rajiv Gandhi Cancer Institute. Dr. Shagun has more than 93 publications in peer-review indexed journals. Senior consultant, sorry ma'am. Welcome, ma'am. Yeah, that's
Hello.
Yeah, it's audible.
Hello. Am I audible?
Yeah.
First of all, I'd like to thank Dr. Praveen Kaur for inviting me here on this academic feast, and then congratulations for holding the first annual conference of Onco Critical Care. And the topic is really important here. It's cancer pain management. And according to the WHO guidelines, cancer, we've got, more than 18.1 million new cases annually. And 9.6 million cancer deaths every year. So statistics are mind-boggling. And 55% of patients undergoing cancer treatment, these people have pain. So addressing their pain is of utmost importance. So on that note, I'd like to invite Dr. Rohit Gulati, Senior Consultant Pain Management at Nivan Integrated Pain Solutions. He's been practicing interventional pain management for 13 years, and he's the Treasurer, Indian Society for Study in Pain, Delhi branch, and he's also the Vice President of the Onco Critical Care Society. Welcome, Dr. Rohit.
Thank you, Chairperson, for the lovely introduction. And as ma'am rightly said, the 90% of onco patients, they suffer from pain management. I think if you people remember the famous dialogue of the climax of Bazigar movie, "माँ मैं दौड़ते दौड़ते थक गया हूँ, तेरी गोद में सर रख के सुकून से सोना चाहता हूँ." That aptly fit to the onco patients who require sukoon in their life. And sukoon is whether it is from pain or whether it is from anguish, they require a sukoon or a peaceful life or the end of peaceful life. Even if they are getting treated, their cancer is getting treated, they are recovering, still pain is one of the worst things that they face. They want relief from pain. And I would be rushing through the slides because I can see everybody is waiting for the sessions to end now. It's quite late in the evening. So I'll just touch a few important topics when it comes to. So in all cancer patients, as ma'am rightly said, 90% of patients, they feel pain. In cancer patients, whether being treated, not treated, terminal illness or whatever, cancer pain remains one of the most common and most troublesome and dreaded symptom for all the patients of cancer. So why do we need pain management as of now? People may ask, like sometimes in terminal cancer patients, even the relatives comes to us, sir थोड़ी सी तो जिंदगी बची है, कट जाएगी, दर्द करके क्या दवाई देके क्या करेंगे, इसमें क्या फर्क पड़ता है? Yeah, either when we tell them that this is particular procedure, it would treat the pain or it would relieve the pain for 6 months, or it सर मरी जाना है इन्होंने, देख लो कुछ करने की ज़रूरत है तो नहीं तो चल तो रहा है काम. This is what the actual outlook is of the family members when it comes to treating pain of an onco patient. So pain, what it leads to, it leads to rehabilitation interference, because even if you treat the cancer, the patient is so died of the pain, he might not actually die, but is died of the pain that he doesn't want to live any longer. Whether the chemotherapy is going to treat him or not relieve his cancer, he is not bothered. He's like, sir, dard ne maar diya, ab ji ke kya karunga? So patients want relief of pain. It interferes with their rehabilitation, their nutrition. The most common reason of losing nutrition and losing health was in a fight with cancer is not because the cancer is lighting the body from inside. It is also because they don't want to eat, because they have lost the hope, because they are so much in pain. And they have limitation of their day-to-day activity, which puts them onto stress, and they land up in depression most of the times. and they stop taking treatment, even they are not willing to go ahead with the chemotherapy. So in types of pain, there are basically two types of oncopains. One where the nerves are just sensing the painful stimulus, and another one where the nerve is actually entrapped in the cancerous tissue or getting a pressure. So neuropathic is when the nerves are actually troubled. Nociception pain is actually where the receptors are sensing the pain and they are transmitting the pain. Nerves are as much per se not damaged. So they are basically two different types. Nociceptive pain is usually visceral, can be somatic, but they are usually dull, aching kind of pain. Whereas neuropathic pain, they may be sometimes shooting pains or they are acute. And nociceptive pain, they mostly respond to opioids and anti-inflammatory drugs. Whereas neuropathic pains, they respond to other drugs like antidepressants and anti-epileptics. Assessment of pain. In this is very common. Like WHO, it had made it mandatory as the pain to be categorized and documented as a fifth vital sign. But it is no more relevant. They say whether you document it because visual analog scale was used to analyze the pain. But it is no more relevant, especially in onco patients, because many a times patients are so much under the effect of narcotics that you cannot assess whether the patient is. So you have to depend on various other factors, whether patient is agitated or not, whether patient is responding to you properly or not, whether patient is refusing food, whether even if the patient is comfortably sitting at home, if the patient is in pain, might not even like to listen to the music, like to watch TV. So you have to judge on different parameters. If patient is in ICU, you have to look at the heart rate, the sweating, the agitation, the you can say non-compatibility to the drugs that you are giving, or even for that matter, even patient do not want to talk to you, they want to be reclusive. So all those things are there which we have to judge and assess whether patient is feeling pain. Only looking at the visual analog scale or the numerical scale is no longer being used as assessment of pain for the cancer patients. And another thing in this regard is one more thing we need to look at is the pain which is because of the cancer may not be the only thing. A patient of 70 years suffering from a spindle cell carcinoma or squamous cell carcinoma may as it is be having a pain of osteoarthritis or a lower back pain with spondylolisthesis. So we need to analyze the pain and look at the character of pain, whether the pain is per se because of the cancer or is it because of any other reason that may be age related. Sometimes we just ignore the age related problems and we try to treat the patient's pain which is only because of the cancer. So we need to look at the patient as a whole, not only because the patient is having cancer, this is having a pain, and just label it that this is onco pain. So we need to characterize the pain. We need to look at the character of the pain, the types of the pain, and basically also the requirement of the patient, what the patient wants. For this, we can create pain diaries. We can suggest the patient whenever the pain occurs, what type of pain occurs, they can document it. And on our rounds, or as we were discussing palliative care and hospice care, the nursing staff or the dedicated healthcare person who is visiting the patient can go through these diaries and look at. And again, WHO pain ladder. No lecture on pain management can be complete without showing this picture. Basically, starting with the low level NSAIDs, going to higher levels, and then adding on opioids, and then adding on higher opioids, and mixing the drugs, mixing and matching. This will relieve the pain, but obviously the side effects of all these drugs will add on. Vomiting from the analgesics like tramadol will add on to the vomiting of the phentermine and fortwin. So you need to take care of the combinations that you need to mention. But along with this, along these three steps of the ladder, next two steps have been added, that is the intervention steps. And in case it is required, we sometimes bypass the second and third step. After the first step, if the need arises, we can straightway shift to level 4 and give the interventional procedures. Interventional procedures basically are two types. One is where the nerve blocks and neurolysis of the peripheral nerves. Another one is where there are irreparable destructive methods like cordotomy, rhizotomy, which cannot be recovered. But otherwise there are blocks, epidural blocks, spinal cord stimulators, baclofen pumps to release the spasticity, or RFA, cold or hot, whichever, it does not matter, to relieve the pain, which do get reversed automatically, or which we can stop giving the drugs, whether it is through patient controlled analgesia or whichever mode where they are reversible. So we have the nerve blocks right from head to toe, starting from trigeminal neuralgia, or in case any intracranial problems are there, stellate ganglion, glossopharyngeal nerve, sphenopalatine block, celiac block, hypogastric, superior hypogastric, inferior hypogastric, ganglion impar block, sciatic nerve, all the nerve blocks, all the peripheral nerves and central ganglions, they are amenable to neurolysis and radiofrequency ablations. So in case need be, we can shift right from level first step to fourth step and reduce the patient's suffering. Usually we do not go to step 5 unless and until it is a very severe pain, not being treated by anything else, and it is sort of end of life care. In onco patients, adjuvants like radiotherapy, especially in the bone tumor pains, chemotherapy and antidepressants like duloxetine and venlafaxine in neuropathic pains associated with depression, or mirtazapine with the patients with anorexia and insomnia. These are just the adjuvants. Similarly, gabapentin and pregabalin, which we use otherwise also in pain management, are very helpful in treating neuropathic pains in onco patients. Similarly, hormones for the hormone-related cancers like prostate and breast cancers and ovarian cancers, bisphosphonates again for the bone-related pains. And next step that has come up, new thing, or it was there previously also but went unrecognized, is cognitive behavior therapy and multidisciplinary therapy, which has got FDA approval of late. In this, we involve various facility people like psychotherapists, spiritual guidance people, physiotherapists, nutritionists, and the pain management consultants. We involve all of them, make a team, and address all the aspects of pain management, and especially towards the end of life care, where patient wants spiritual stability, patient wants movement, patient wants good nutrition, basically respecting the patient's life towards the end. There are a few barriers in inadequate pain management in onco patients, basically societal attitudes towards pain management. As we have already discussed and I have mentioned in my previous slides also, approach towards pain is दर्द ही तो है, एक गोली खा लो ठीक हो जाएगा, is the basic attitude, which does not take away the root cause of pain management, which is very, very limiting in pain management. Almost, if you people also would have observed, if you don't tell that you are a doctor, almost your barber, your grocery shop owner, your sabji wala, to the even to the dhobi that you go to, everybody will be able to tell you a painkiller every now and then. Whenever you go them, in case you mention in front of them, yaar dard ho rahi hai, even they will be able to spell 2 painkillers for you. System and regulatory barriers come in picture when we need opioids for the patients. They are not freely available. You need to maintain documentation. You need to have licenses for procuring as well as for prescribing these drugs. Even for the stockists, they need big registers to maintain. So that creates a big problem for the availability. Clinician's barrier comes in picture when the primary care team, who is actually responsible for providing the pain relief or the onco treatment for the patients, they come across, यार हम 2 दवाइयाँ लिख रहे हैं, ज़रूरत नहीं है किसी और चीज़ की, and patients keep suffering in pain and they keep ignoring because pain is, as we mentioned, is the main symptom of the onco patients, and the primary teams, they get fed up of their complaints and they keep writing without it is, whether it is required, whether it is not required, without modulating the dosage. It is given on PRN basis. सुबह लेनी है, शाम को लेनी है, which the concept has outgone, especially in case of onco patients, because it is not dose based now, it is the requirement based now. Previously we used to give morphine 4 times a day and it used to keep going on for years together, where the patient is requiring it only in the evening. Sometimes the patient requires it only before the sleep. Sometimes patients, if they are mobile patients, they go to temple, they go to shop, they require it according to their timings. So now the need-based therapy or need-based approach is the latest thing. We do not write it as per schedule. We give it according to the need. Similarly, patient barriers, where the patients are not comfortable taking medicine every time. Sometimes they have the hassles, doctor साहब इतनी दवाइयाँ पहले चल रही हैं, why do we need to use that now, अब और कितनी लेनी है? To curb that, to overcome this problem, the companies have come up with transdermal patches, the button devices where the application, where the instrument is applied on your body, and when you need the medicine, you press the button and certain amount of prefixed dosage is inserted into your body, and especially tramadol has come up with this thing. Racial and socioeconomic disparities is again, as in US, the opioids are very freely available. US, Vietnam, Singapore, Switzerland, these are freely available. But in India, In case you need to have all these drugs, you need to be having all the drugs and license issues, which I already mentioned. A few more challenges that come in onco patients, like the drugs that are used to treat the tumors or the cancers, they itself lead to peripheral neuropathy. And like taxanes, vincristine, ixabepilone, and platinum, this is platinum and all. These drugs, they themselves called peripheral neuropathy. So when the drug which we are giving for treatment, as in the morning also doctors had mentioned, the drugs that we are using to treat the patient is leading to further problems. So, and when the patient is, the cancer is not being treated or the tumor is increasing in size, the pain worsens, whether it is because of the pressure or whether it is because of the more nociceptors getting involved or more nerves getting impinged, the pain requirement is increasing. The medicine for pain needs to be increased along with the time as the disease progresses, and patients do get nervous that पहले जब शुरू किया था तब तो एक गोली से काम चल जाता था. Now more and more medicines are required, so they start losing hope in pain management as their doctors and primary team per se. Similarly, I just mentioned as the vomiting, constipation, all these side effects like gabapentin you are giving along with opiates, they will increase the constipation. The patient will further feel that it is worsened their symptoms. Pain to pehle si thi, now the bowel is not also getting empty, they are not comfortable. Similarly, tramadol added with fentanyl with a cervical spondylitis patient or a cancer of abdomen will lead to further vomiting issues. So patients get more nervous with the added on side effects. So too many drugs, too many cooks spoil the broth. So too many drugs might not relieve the patient's pain, but they will surely add on to the side effects and demoralize the patient. So we are aspiring for a pain-free world. Thank you very much.
Thank you, Dr. Rohit, for an excellent presentation. Audience, any queries, comments, or questions? Anybody? Well, Dr. Rohit, could you educate us on the role of ketamine? You know, ketamine can be given IV, IM, orally, intranasally. So, could you tell us how effective it is in management of cancer pain? Does it have any role?
Ma'am, ketamine, as of now, we are using only in the ICU setups, and we are giving intranasal drops. But IV, if we give it, we only prescribe it during the patient's stay and acute conditions of pain during the hospital stay in ICU setups. It has to be added with adjuvant drugs because, as we all know, ketamine causes a lot of bronchoria as well as a lot of aggression in the patients. So we need to add on midazolam or other propofol infusions along with that. Maybe dexmedetomidine. So along with that only we can give it along with lot of anticholinergic support.
So yes, ketamine is an old drug, but now it's in a new bottle. And what we have here is we have some new trials based on oral ketamine. You're giving 0.5 milligrams per kg body weight 12 hourly. And this ketamine can help you reduce the opioid dose because it's a very, very effective analgesic, even better than morphine in certain cases.
Sure, ma'am.
And secondly, it can relieve opioid hyperalgesia. Ketamine. Then intranasal ketamine is being used for, relief from breakthrough pain. You know, you're giving opioids round the clock and patient's pain is not being relieved. So now you're giving ketamine for that.
I have not yet used it. So thank you so much for
all
add-on.
These are up and coming. Past few years, 2-3 years, it's seen a resurgence in the ketamine. No, it's come back.
Because presently it is a scheduled drug, so it cannot be prescribed on OPD basis.
Yeah, exactly. So where would you place it in the WHO ladder?
I think let it come to the market in the preparations only, then WHO would incorporate. Presently,
it's already there. Oral ketamine is there.
But it cannot be prescribed as of now without the schedulings.
So similarly, morphine.
Yeah, I think it would be. I think it would be the adjuvant only with the step 3 ladder. After the step 3, if the patient is having breakthrough pains, even still with the higher opioids and with the analgesics, NSAIDs and opioids combined, patient is still having the breakthrough pains only. I think then it will come in picture.
How about local anesthetics?
Usually doesn't work, ma'am.
No?
No, usually doesn't work, ma'am.
And the blocks?
And that also for, again, the side effect or the side effect profile is very high for local anesthetics to be given. So I don't think we would be prescribing it for the oral purpose and at home usage for the patients. Basically, side effect profile is what we have to be very careful because patients are already very nervous about.
Because that's what I'm worried about, the opioid pandemic, the addiction and all
Yes,
that.
ma'am.
So these adjuvants will help you reduce your dose of opioids, reduce your
But
nausea,
ma'am,
vomiting,
as we have already
constipation.
discussed, sorry to interrupt you, as we have already discussed, if we cannot do any good to the patient, we shall not do any harm
First
to
of
the
all, do
patients.
no harm.
Yes, ma'am. So
Primer,
this
no nausea.
local anesthetics presently, and per se, my reservation towards ketamine still is, I will still wait for a lot more trials and much more availability to be there in the market to prescribe it on the OPD patients and to be used, because as we all know, it's famous as the rape drug. So it's very, very risky to prescribe such a thing and getting it in the wrong hands.
True that, but it might help.
Might help, ma'am. Let's see. Let's
how
see the
future
trials to
unfolds
come. Yes,
for
ma'am.
ketamine.
That was an excellent presentation. That was an excellent presentation by Dr. Rohit, and I'd like to add this, whenever we give opiates, no opiate is too much for the patient unless we can relieve the patient's pain, unless the patient cannot tolerate it or the adverse effects are very high. So that is another thing which is important aspect in this pain management.
But the best part about opioids is, as long as patient is not relieved, except for the constipation and nausea, no other side
You can
effects
always
come.
increase the dose.
Yeah, you can keep on increasing the dose and no side effects come till the pain is gone. Only once the pain is gone and we overprescribe it, that the side effects start coming. So that's the best part about the opioids using in onco pain.
Yes.
Thank you, ma'am.
Thank you so much, Dr. Rohit. I would now request the chairpersons to felicitate Dr. Rohit, please. Thank you. May I now request Dr. Saurabh Das to felicitate Dr. Shagun Bhatia? Requesting Dr. Praveen Kaur to felicitate Dr. Sujali, please. Thank you, madam.